دكتورة هويدا لسه معانا ولا سابتنا؟ طيب لو الدكتورة هويدا مش موجودة، دكتورة سحر بعد إذنك قدم لنا الدكتورة سالي جودة.
بالتالي الدكتورة إلهام أحسن من يقدمها.
طب خلاص يا ريت. اتفضلي
دكتورة إلهام.
اتفضلي دكتورة إلهام لو كنت بإنك تقدميها.
الحقيقة سالي بنتي، فأنا شهادتي فيها مجروحة، بس هي من أكتر الناس في وحدة الحساسية والمناعة كين على المرضى، وعندها استعداد إنها تضحي وتفضل قاعدة معاهم فترات طويلة، ودايما تستنجد في كل إمرجنسي. فالحقيقة لما الأستاذة الدكتورة إيمان زكي قالت لي على الفكرة الجميلة لهذا الويبينار، أنا لقيت إن سالي هي إن شاء الله أقدر واحدة على إنها تتكلم فيه بإذن الله. شكرا جزيلا.
العفو، دي شهادة تعتز بيها جدا جدا يا سالي. والأستاذة الدكتورة إلهام قامة كبيرة جدا بتشرفنا بمساندتنا جميعا من أول يوم لحد الآن، وهي مثل يحتذى في كل المجالات، وأنا يعني أثق جدا في رأيها وتقييمها للناس، فإن شاء الله هنستفيد من محاضرتك جدا يا سالي، وختامه مسك بإذن الله. اتفضلي.
بإذن الله حضرتك. بشكر حضرتك أستاذة الدكتورة إيمان زكي على إتاحة الفرصة لوحدتنا للمشاركة في هذا الويبينار الرائع، وبشكر أستاذتي الغالية أستاذة دكتورة إلهام على ترشيحي وإعطائي هذه الفرصة. I will start my presentation with a case from our clinic. She's a female patient, 14 years old, first order of birth of non-consanguineous parents. Her condition started 8 months before presentation with constitutional symptoms, extensive oral ulcers, and bilious skin lesions. Then 2 months later, patient developed cough, dyspnea, and cyanosis. She was admitted to the pediatric intensive care unit. CT chest was done for her, showing interstitial lung disease with bronchiectatic changes. Then the patient was on oxygen therapy. She started a pulse steroid for 3 days on 30 milligrams per kg together with the systemic antibiotic and frequent nebulization. Her condition improved regarding the skin rash and slight improvement in her chest condition, and the patient was discharged on full dose oral steroids. Then 1 month later, the patient presented to us with abnormal behavior, hallucinations, and suicidal attempts. Here our provisional diagnosis was toward the possibility of an autoimmune disease presenting with psychiatric manifestations. So again, the patient received pulse steroid therapy and started cytoxan on 500 milligrams per meter square together with antipsychotic drug, after which she showed improvement regarding hallucination and the communication with her family and no suicidal attempt. On examination, the patient was alert. She was vitally stable. There were the extensive oral ulcers and the bilious rash on the neck, hands, and feet with nail dystrophy, which was found later to be lichen planus by skin biopsy done for her. The chest was revealed bilateral diminished air entry with the sibilant bronchi and fine crepitation all over. Her cardiac, abdominal, and neurological examination was free. After doing the laboratory investigations and the various immunological markers, the case was proved to be a systemic lupus erythematosus with psychosis. The association between immunological process and mental disorders was observed by doctors centuries before the immune system was discovered. Psychosis arising either with the occurrence or disappearance of acute fever has been described by many scientists from Hippocrates around 400 before century to Kraepelin around 1900. In 1930s, it was first hypothesized by Hermann that schizophrenia was the product of an autoimmune reaction with antibodies attacking the brain tissue. Additionally, the autoantibodies cross-reacting with brain antigens were discovered in patients with schizophrenia back in 1960s, and there was an increased interest in the antineuronal antibodies in psychotic disorders during the last couple of decades, with increasing number of records on previously unknown antibodies with brain reactivity in patients with psychosis. The vast majority of the epidemiological studies found an association with between the autoimmunity and psychotic disorder. A Danish study was done on 7,700 patients with schizophrenia, and there was found an increased prevalence by 45% of the occurrence of an autoimmune disease. Then two Danish register-based studies found that individuals with psychotic disorders had subsequently an elevated and increased risk for autoimmune diseases. In 2013, a study done on 3.6 million people in Denmark who were diagnosed with an autoimmune disorder, 45% of them were found to be diagnosed later with a mood disorder. In 2018, a meta-analysis was done on 25 million people, and the researcher found a positive association between being diagnosed with psychosis and having an autoimmune disease. Autoimmune diseases and psychosis are not only associated on an individual level. Having a first-degree relative with psychotic disorder will increase the risk of the autoimmune disease with 6%, and also the family history of autoimmunity will increase the risk of both schizophrenia and other psychiatric manifestations with 10%. Regarding the pathogenesis of autoimmunity in psychotic disorder, it's multifactorial with multiple etiological factors linking between the autoimmune disease and the psychotic disorders. Starting with the genome defect, which increases the susceptibility to infection, together with the dysfunction in the microbiome and psychological stress. All these will induce an abnormal immune response through the dysregulation of T and B cell and production of autoantibodies. Also, the induction of a chronic inflammatory state in the brain. On exposure to infection, the permeability of the blood-brain barrier increases, allowing the entry of the immune cell, the pro-inflammatory cytokine and circulating antibodies into the central nervous system, which in turn cause an inflammatory state in the brain. The microbiome composition is very important in the development of both the central nervous and immune system. The dysfunction or the dysbiosis of the microbiome affects the T helper 1, T helper 2 balance and the ratio of T regulatory cells by decreasing it, and T helper 17 cells by increasing its level, thus impacting the immune response to foreign pathogen, which subsequently impair the social functioning, behavior, and cognition. Psychological stress and physical stress, as well as sexual abuse, increase the circulating pro-inflammatory cytokines such as interleukin-6, interleukin-1, beta, and T and F via the sympathetic nervous system and the hypothalamic pituitary adrenal axis, contributing to a chronic inflammatory state with immune dysregulation. Which also the psychological stress was found to affect the microbiome composition and increasing the susceptibility to infection as well. Coming here, there was certain indicators that help to increase the detection of autoimmunity in patients presenting with the atypical psychiatric presentation, or having a cognitive dysfunction, or presenting with an acute behavioral and personality change. There are a lot of autoimmune disorders which can present with psychiatric symptomatology. For example, the systemic lupus, the Sjogren syndrome, sarcoidosis, scleroderma, multiple sclerosis, myasthenia gravis, polyarthritis nodosa, and some autoimmune endocrinal diseases as Hashimoto and Addison. So what are the common psychiatric manifestations which can be found in the different autoimmune disease? Coming to systemic lupus erythematosus, the neuropsychiatric symptom prevalence without reliable imaging or laboratory data has been estimated as acute confusion, appearing with about 15% psychosis, about 10%, followed by the other psychological and psychiatric manifestations. Also in the primary antiphospholipid syndrome, psychosis with delusion and hallucination are being the most common presenting in these patients. The most common psychiatric abnormality in Sjogren's syndrome was found to be the cognitive dysfunction together with the anxiety and depression. Also recently, psychosis was found to be an initial presentation in pediatric Sjogren's syndrome in adolescents. Depression and anxiety are the most consistently observed disorders together with cognitive dysfunction in Behçet disease. And in rheumatoid arthritis, the depressive symptoms and anxiety are frequently associated with rheumatoid arthritis, especially in adolescent females, owing to having a high level of pain and the presence of a great number of painful joints. Psychosis in neuropsychiatrosis was found to presents more with the paranoid type with behavioral disturbances and cognitive impairment. In scleroderma or systemic sclerosis, depression was found to be the most common psychiatric symptom, appearing in almost half the cases. Also, patients scored higher on measures of anxiety, paranoid behavior, obsessive compulsiveness, feeling of guilt, and cognitive impairment. And finally, in multiple sclerosis, depression is the most frequently seen, also in half of the patients, and suicidal risk was also great. I will focus more on systemic lupus erythematosus as being the most common autoimmune disorder in practice, presenting with the psychiatric manifestations. Systemic lupus erythematosus is an autoimmune disorder involving virtually any organ system with a myriad of clinical manifestations. The American College of Rheumatology established case definition for 19 central and peripheral nervous system syndromes, which are known as the neuropsychiatric SLE. The psychiatric manifestations in the form of cognitive impairment, mood disorder, anxiety disorder, psychosis, and acute confusion are classified as diffuse central neuropsychiatric SLE. The neuropsychiatric SLE are present in about 80% of SLE patients, especially those presenting or having a coexisting antiphospholipid syndrome. It can present before or at the diagnosis of SLE in about 40% of the cases. A diagnostic delay of 6 to 9 months from disease onset was reported, and it's very important as they initially present with absence of the clinical or serological SLE activity, and the patients then present more to the psychiatrist rather than the physician. So it's very important for this patient to be followed closely and to repeat again the clinical assessment and the serological and immunological markers after 6 or 9 months for possibility of the appearance of an autoimmune disorder. 80% of acute psychotic episodes present within 1 year of diagnosing the first time presentation of SLE. The pediatric and young adult patients are the more at risk of developing the psychosis related to SLE. Skin vasculitis, serositis, and pulmonary involvement are the most common extracerebral manifestations in lupus psychosis. So it's very important also to closely follow up patients presenting, especially with the cutaneous manifestations, and an SLE patient, they have the more possibility to develop later lupus psychosis. Regarding the neuropsychiatric manifestations, cognitive and mood disorders were the most common, about 80% of the cases, while psychosis, mainly as visual hallucinations, have been reported in about 10% of the cases. The presence of the neuroinflammatory markers in CSF, disease activity marker in the blood, and responsiveness to immunosuppressive agent point us toward the diagnosis of neuropsychiatric SLE. MRI show no abnormality, and it's very important that it doesn't show any abnormality in 40% of the cases, despite they are clinically having the autoimmune disease. Psychosis in SLE can occur either due to neurolupus or drugs used to treat it, the most commonly the corticosteroid followed by chloroquine, or due to the flare-up of the premorbid psychiatric condition due to disease burden. The steroid causing or induced psychosis is dose dependent. It occurs more with those having higher doses of steroids, more than 40 milligrams per day. It starts within about 1 to 2 weeks of starting steroids and improves on withholding or decreasing the drug. Mania or depression are commonly associated with the steroid-induced psychosis. Mania appears more or presents more in patients having the short-term steroid therapy, while depression with those on long-term steroid therapy. Also, auditory hallucinations are frequently reported as well. SLE patients are more prone to develop the steroid-induced psychosis if there is concurrent lupus nephritis causing hypoalbuminemia. There is no exit mechanism which can clarify this, but the most possible explanation that patients with lupus nephritis having hypoalbuminemia will require higher doses of steroids, so they will be more liable to develop lupus psychosis. The long-term outlook of psychosis as a neuropsychiatric SLE is favorable. 60% show complete remission after about 1 year of appropriate treatment. Regarding the management, first, it's extremely important to distinguish whether the psychiatric symptoms are primary to an underlying disease, which is mostly in our case an autoimmune disease, or secondary to treatment. So we have to first control the underlying disease activity. The clinical consensus of treatment strategies involves the rapid initiation of treatment in those patients to suppress autoantibody production by starting steroids, or then having a long-term maintenance therapy on the steroid-sparing agents. Also, other choices like immunomodulation with IVIG or plasma exchange to remove the circulating autoantibodies is a second choice. Recently, also, the biological therapies can be used. Psychiatric medications are required for immediate symptom control. Risperidone and olanzapine are the most commonly used. Prolonged treatment with the antipsychotic drugs is not recommended. Once the patient's symptoms successively improve, the antipsychotics should be gradually stopped, and this takes about 1 month. For drug-induced psychosis, the most important is to stop the drug. Beside the psychological, the pharmacological therapy, it's very important to decrease the psychosocial stressors, increase the social support system, improve the physician-patient relationship, start supportive and cognitive behavioral psychotherapy, and educate both the patient and the family about his disease. My take-home message that research in the field of psycho-immunology is still evolving, with many different aspects being investigated. Understanding the link between autoimmune disease and mental disorders may shed light on possible etiological mechanisms herein. Furthermore, this will give rise to a wide range of new treatment options in psychiatry, amongst other possibility to identify subgroups of patients with psychotic disorders and ongoing inflammatory process that could benefit from more targeted treatment and having a good impact on the outcome of patient. Organic disorders should be always kept in mind while evaluating any case of acute psychosis, as they generally harbor reversible causes with a better outcome. Among young females with acute psychosis, the autoimmune disorders should be considered. and thank you for your listening.
شكرا جزيلا دكتورة سالي. طبعا الأستاذة الدكتورة إلهام مش محتاجة يعني حد يصف قد إيه قدراتها في إنها تختار الشخص المناسب في المكان المناسب. الحقيقة